And that's what I'll be discussing. I have written numerous chapters in every textbook of critical care medicine, so if you have a textbook of critical care medicine and there's a chapter on heart-lung interaction, read it. It'll be the same thing as this because I wrote it. Okay. These are my conflicts of interest. They're not relevant to what I'm going to talk about today. Okay. Ventilation is cardiovascular stress. If you understand that, you understand why patients fail a weaning trial. Spontaneous breathing is exercise. It's exercise in every sense of the word. It uses skeletal muscle to contract, uses oxygen, requires blood flow, and produces CO2. If you don't have enough heart function to walk up a flight of stairs because you're in heart failure, maybe you don't have enough heart function to breathe if you have increased work of breathing. Spontaneous breathing, by decreasing the pressure in the chest, sucks in blood into the lung, increasing the preload of the heart, intrathoracic blood volume, and impeding left ventricular ejection. And positive pressure ventilation does the opposite. If you understand all three of these things well, then you know everything that I'm going to say, because I'm only going to repeat them. Breathing is exercise, and the number of studies that have shown that breathing is exercise is too numerous to count. My favorite one, though, is by Zev Masenafar and Amal Jabran. What Zev Masenafar said is that if breathing is exercise, if I take a person in heart failure and exercise them, they get gut ischemia because they can't perfuse their gut. So let's measure gut ischemia with a tonometer. And what they found was in patients with COPD who would be weaned, their initial PHI of the gut was there, and when they finished their weaning trial successfully, there was no difference. In other patients with COPD on a mechanical ventilator, their PHI was statistically significantly lower, but was within the normal range. However, with exercise, there was profound gut ischemia to the level you would expect to see with circulatory shock. If this was true, Amal Jabran argued, you should see the mixed venous O2 sat fall precipitously during a weaning trial, but if your cardiac output can match it, it won't fall at all. And that's exactly what she showed. As you can see, if you measure mixed venous O2, if I don't have enough oxygen delivery to use the oxygen consumption, I increase my extraction ratio and my venous O2 sat falls. It is actually a terrible, violent storm weaning a person from mechanical ventilation. And all the cardiovascular insufficiency we see associated with mechanical ventilation is associated with starting it or stopping it. Potentially, the reason why all weaning parameters are terrible at predicting who can wean from ventilation is because none of them have included in them cardiovascular reserve or its determination. That's why today we say, I have absolutely no idea if my patient can wean, so I'm going to throw him over a cliff and see if he flies, otherwise known as a spontaneous breathing trial. You do that because you have no idea, and the reason you don't is you can't assess the work of breathing. Okay. Exercise limitation is the big fish, and this is a 24-inch rainbow trout caught on a fly, and I did release it after this picture was taken. If weaning is exercise, then I could use it as a cardiovascular stress test, right? An exercise stress test. And the number of studies that have shown that weaning induces coronary ischemia is again too numerous to count. My absolutely favorite was the one by Francois Lemaire from Crité in Paris. And he did this wonderful study when Warren Zapel was around with him in his hospital on sabbatical, looking at weaning. And what they did, and one of the authors in that paper, by the way, was Jean-Louis Toul, is they took patients with chronic obstructive lung disease and they tried to wean them from mechanical ventilation. And they measured esophageal pressure, which is the pressure right here, and they measured pulmonary occlusion pressure. The esophageal pressure was about, it looks like 4, which is reasonable because in a supine position you've got the heart on the top of the esophagus. And you can see from this that the patient's straightening the ventilator, positive pressure breath. Your pulmonary occlusion pressure, to my eye, is about 18. Then he put them on a T-tube trial, and you can see that the end-expiratory esophageal pressure became more negative. And that's because the patients hold their lungs at a higher lung volume by expiratory braking. But if anything, there was not an increase in intrathoracic pressure. And with every breath, the pressure fell down by 25% 5 millimeters of mercury. That's a significant negative swing. That sucks blood back into the chest, and the pulmonary artery occlusion pressure rose to 45. 45 millimeters of mercury, pulmonary occlusion pressure is very, very high. You cannot live there for more than a few minutes. By 9 minutes, the patient had